Um, Hello, everyone. Thank you for attending our webinar, Understanding Self-Harm. My name is Gabriella Nyman, NCCAS's Training and Communication Specialist. Before we begin, I'm sure most of you have been living on Zoom, but just in case you aren't aware, if you have any questions during this webinar, please type them into the chat box or into the Q&A, and me and Deanna Harrington will be monitoring those. I'm excited to introduce our presenter for our webinar today. Dr. Kim Benton is a licensed psychologist and certified eating disorder specialist. She began her path towards being a therapist by volunteering at Orange County Rape Crisis Center during her undergraduate years. Dr. Benton continues to use that training in her daily work with people recovering from trauma. Dr. Benton, thank you for being here with us today.
Thanks, Gabriella. Hi, everyone. I'm Dr. Benton, as Gabriella said. It's an honor to be here with you all this afternoon. I notice about myself when I do these Zoom presentations that I do tend to speak a little bit more quickly than I do in person, just because I don't have that face-to-face feedback. So I apologize for that in advance. I will also let you know that I am home with my 3 large dogs. And I am sure that regardless of what happens, I will have to stand up at some point and let one of them in or out of the room that I'm in. That's just how it goes. So today could potentially be a tough topic for folks. So please feel free to take care of yourself, take breaks, pop in and out if you need to. Self-harm can be something that is very personal for folks. A lot of people experience it, as we will talk about. And so understanding that about yourself and kind of being ready for those potential pieces to come up for you. So with that in mind, the first thing that I want us to do is to take just a minute to take some nice deep breaths with each other. Just finding a comfortable spot in your seat, sitting on the floor if you need to, finding a nice relaxed position, sitting up somewhat straight to give your lungs room to breathe. I invite you to close your eyes if you're in a space where that feels comfortable. You can rest your hands wherever that's comfortable for you. Relax your jaw, try to relax your brow. Just focus on the breath coming in and out of your body. Noticing how your body moves as you breathe. Letting yourself relax into that breath and just letting your body breathe. If your thoughts begin to wander, that's okay. Just notice them and let them go and come back to the focus. Noticing how the breath comes in through your nose, down your throat and into your lungs and even into your belly. And then back up through your chest, your throat, and out of your nose again. As we come to the end of this moment of quiet breathing for ourselves, try to deepen your breath, noticing how that feels different when you focus on a deeper inhale and a deeper exhale. Maybe allowing yourself to set an intention or to give yourself an internal hug as we work through some difficult topics today. And slowly coming back into full awareness here. So do that at the beginning of our presentation here, because anytime we're in a situation where we really need to focus or something might feel stressful, it's a good chance to take that opportunity to check in with yourself, to notice if you have any concerns or thoughts that are coming up for you. I also wanted to give you a little bit of a sample of things that you can do with a client if they're calling in on one of the crisis lines, or potentially sitting in front of you or Zooming with you, to help them calm and ground themselves also. And I think that can really help when we know what that feels like. So again, I'm Dr. Kim Benton. I am a licensed psychologist in North Carolina. I was also licensed in the state of Georgia before moving to North Carolina. But I got my start as a counselor at the Orange County Rape Crisis Center in Chapel Hill, North Carolina, when I was a student at UNC. And I trained there as a crisis companion and a support group facilitator. I actually graduated before I got to lead a support group, but those trainings really did set me up for the work that I do today, and really helped me to be able to get into grad school, because that is experience that grad schools like. So that's always appreciated there. But I say that to let you know that I do understand some of the pressures that are going on for folks in the rape crisis world right now. Especially with the increased numbers of domestic violence and probably more severe issues that are coming through the crisis line than maybe have in years past, just because of the place we are in the world right now. So anytime I do a presentation, and if you were in the last one that I did, I always want to point out any potential bias that I may have. And I do this not necessarily because I'm thinking that that bias may be impacting what I'm saying, but with the knowledge that it could be. I come from a particular background, from a particular culture, with a particular set of knowledge and understanding. And so there may be things that I miss because of that. There may be things that seem more important to me because of that. And so these are some of the potential biases that I may have. And again, this is something for you to think of for yourself too as you're working with clients. So as we get into talking about the idea of self-harm, I wanted to share this quote from Dr. Scott Lyons. He's a psychologist who works in the field specifically around self-harm issues. And he says, "The skin becomes a battlefield as a demonstration of internal chaos. The place where the self meets the world is a canvas or tabula rasa on which is displayed exactly how bad one feels inside." This quote could have come from any of my clients, minus the tabula rasa. They're not probably going to use that phrase. That just means blank slate. Again, a canvas to be used to show people how you're feeling. So when we talk about the idea of what self-harm is, what exactly are we talking about? Clearly, the thing that we're talking about is something that is harmful to the self. But there are some other caveats that go with that. So one of those is that it's a deliberate act. So it's done purposefully. That means that a person is intentionally doing something to hurt themselves. However, there's sometimes little pieces when we talk about some types of self-harm, such as binging and purging, where they're not always thinking of that behavior as harmful. They may be thinking of it more as a habit. And even sometimes for people who cut, they're not necessarily thinking that they're doing harm in some way, but they are thinking that they're hurting themselves. And so they're purposefully attempting to hurt themselves, even though they may see it more as therapeutic. And that's a tough distinction to describe. So feel free to ask me to clarify that more if you need me to. Another piece is that it's self-harm that's done directly to self, meaning that it's not done by getting someone else to hurt you. So the idea of people who kind of go out and pick fights, while that is self-injurious in a lot of ways, it's not considered the type of self-harm that we're talking about today. And for the most part, this is behavior that's not suicidal. So I know one of the things that can be very scary for folks who don't often work with people who self-harm is that they're worried that this means that this person wants to kill themselves. This is especially true when I speak to parents or loved ones of people who self-harm. It's a very shocking behavior. And so oftentimes when family comes in, they're panicked, they feel traumatized themselves, they've typically caught someone or surprised someone that they care about in this behavior, and they're incredibly worried that what this person is trying to tell them is that they want to die. And more often than not, that is not the case. That doesn't mean that they're not at increased risk for suicide, but it means that that's not typically the goal of this behavior. And I'll talk about that a little bit more in a slide as we move on. So any questions about a definition of self-harm before I move on? So the other thing that I want to talk about is methods of self-harm that you might see. And some of these you would probably think of right off the top of your head. 9 times out of 10, if you're talking to people about self-harm methods, the first thing that they're going to think about is someone who cuts. That is the most common. I think it accounts for about 85% of the people who self-harm, if I'm remembering correctly. Between that and self-burning, those two are, I think that leaves about 5% left as far as people who self-harm. So other things that we might see that are still considered somewhat common methods are hitting. And they can either use their hands to do that. I've had clients who have used their fists to create bruises on their thighs, or to hit themselves in the head. I've also had clients who have used objects to hit themselves, hammers and other types of things. So you may hear someone talking about that. You may also see someone who's head banging, so actively hitting their head into something else. Or scratching. And I put scratching on here specifically to have the conversation about being really careful about how we talk about self-harm methods with the people that we're talking to. And the reason for this is because oftentimes what will happen is that a teenager in particular will start self-harm by scratching. And what that means is that they've literally taken their fingernails and they've scratched somewhere or picked a scab or something along those lines, not letting an injury heal. And they've come into contact with a professional who has said something along the lines of, oh, well, you're just scratching, so that's a good thing. What I have seen that do for people who are particularly trying to express some form of pain that they're experiencing is that feels very invalidating. And so they will sometimes escalate their behavior in order to prove to people that they are really hurting as badly as they are. And so we want to be really careful when we're talking about any of these types of self-harm, not to say, well, it's just this, or, well, it's only, or, well, thank goodness you're not doing the bigger thing. Or I had one student at one point whose guidance counselor told her that she was not actually self-harming because she was just scratching. So we want to be really careful to avoid that type of language, especially with any teens that you're working with. Other things you may see that are less common is purging, and typically this is a form of forcing yourself to vomit. Excessive tattooing with the goal of the pain being why they're doing it, or excessive piercing for the same reasons. Binging can also be a form of self-harm that we can see when the goal is to punish self by feeling overly full. And in really severe cases, you can see people who perform amputations on themselves. This is usually during a form of psychosis, but you may also see this with some of your trans or non-binary folks when they're feeling particularly particularly dysphoric about a particular body part. So it is something to kind of be aware of and pay attention to. There are many other ways of self-harming, but those are kind of the primary forms that you will see. And some of the less common forms that you may see, but also to be aware of that they do exist. And so it's not just that, someone who is self-harming is cutting. So one question that a lot of people ask is self-harm dangerous? Which seems like a clearly obvious, well, yes, of course it is. At the same time, I think when people ask that question, what they're really thinking about is self-harm deadly? And so again, what I want to say to this is that for most people who cut, they see the cutting or the self-harm as a way to avoid suicide. And so what they will say to me in my office is, well, I self-harmed to avoid suicide. What that typically means is that they are very depressed. They understand that suicide is not something that they really want to do, but they may be having a lot of thoughts about suicide or wanting to commit suicide. And so rather than committing suicide, what they'll do is that they will self-harm in some way as an attempt almost to kind of like snap themselves out of the suicidal ideation, or almost as a bargaining chip of like, well, maybe if I just do this thing, then I won't need to do this thing. And so it's something that you will want to talk about with that client, of asking them, well, were you thinking about killing yourself when this happened, or were you feeling depressed when this happened? But to understand that if they say, no, I really wasn't, or, well, yes, I was thinking about it, but I did this instead, that's actually, it's been shown in research to be very true about people. And so it's not necessarily something where you're going to immediately jump to, well, I have to call 911 and send someone to check on you. That's not necessarily going to be the next step that happens when you're talking to someone who maybe saying, yes, I was thinking about it, but the self-harm helped me not think about it so much. Honestly, when I work with clients, the scariest and most common risk factor for them is going to be infection. They don't tend to be very careful with the objects that they're using to self-harm with. This is especially true when it comes to people who cut. This is going to get into a little bit of the detail, but they have a tendency to reuse objects to cut with. So when I'm working with people who cut, I set some ground rules with them because I understand completely that we're not going to stop them from cutting in one session. And you're definitely not going to get them to stop cutting in one crisis contact. But what I will do is I will set some ground rules for them, especially for people who cut, again, because they tend to reuse objects. But to say that I understand this is something that's going to continue to happen for a little while. However, let's set some things to help you be safe. The first is that whatever implement you're using to self-harm with needs to be clean. You need to sterilize it as much as possible, and you need to clean whatever wound you create afterwards. For some people, just talking to them about that is enough for them to think, that feels like a little too much work. Maybe I'll find another coping skill. For other people, it's a way to keep them from having to go in to a doctor to deal with an infection issue. Physicians especially tend to get very freaked out about self-harm just because it is a very scary thing if you don't understand the psychology behind it. And even then, it is very serious, and I'm not attempting to minimize that, but I want to kind of bring down the freak out factor that a lot of people will have when they see this. The second most common risk that you will see is accidental injury. So not that they have accidentally cut themselves or accidentally burned themselves, but that they have accidentally cut too deeply. or cut too many times, or they've burned themselves for too long, and now instead of the smaller burn that they were expecting, they have a very serious burn. So another thing that I talk to my clients about a lot of times, and if you're thinking about implementing any sort of self-harm policy at your rape crisis center, or helping people to understand how to work with this, is that if they have an injury that needs medical care, that they seek medical care. And this is talking to them about the responsibility of taking care of whatever it is that they choose to do with their body. And so this is somewhat giving them some power back to be able to say, again, I understand you're choosing this as a coping skill, and you're talking to me about it because it feels bad for you. And so we're going to work together to stop this. And I understand you've been using this coping skill for a long time. It works really well. And I understand that you may not stop immediately. So I'm going to do what I can to help with controlling infection, controlling accidental injury. And I'm going to talk to them about what to do if they really are feeling suicidal, and how to start to use their words rather than their behavior to communicate any concerns that they have. Any questions? So how common is self-harm behavior? What are we really talking about here? When we look at adults in the US, this data is specific to the US, we have about 4% of adults who are reporting self-harm behaviors. About 15% of teenagers report self-harm behaviors, and about 17 to 35% of college students report self-harm behaviors. So the spread with the college students is so large because there are so many studies, and they're all over the board, especially around how many participants they've been able to put in those studies. It does tend to be the largest group with self-harm. So it looks like there is a question about self-harm in youth being a mandated report. My understanding is that it is not a mandated report, because they are not a danger to themselves in the way that North Carolina defines what that danger is. Now, your center may have different feelings about that, and they may have a different policy in place. So I would defer to your center. From a psychologist perspective, that's not a mandated report because they're not suicidal, and hospitalizing them is actually not going to be very effective as far as treatment goes. So kind of getting back to this percentage, I think a lot of people think of self-harm as something that is very rare, that hardly ever happens. And as we can see, that's simply not the case, especially when we think about the idea of like something that we think of as very common, such as depression, really only happening in 5% or fewer people in the population. And so to think of it from that perspective, these numbers are kind of astronomical. And so I think it's really important to recognize that this isn't some kind of freak thing that just happens sometimes and is, you know, kind of this rare thing. It happens quite often. Of the clients that I see, if someone's coming into my office, the rates are much, much higher. These percentages are for the general population. So there's one study that was done related to the presence of childhood sexual abuse in people who reported cutting specifically. If I'm remembering correctly, this study had about 500 participants in it, and 93% of the people who reported cutting reported a history of childhood sexual abuse. So you're seeing a very high percentage of people who self-harm report childhood sexual abuse histories. You're also going to see about 85 to 95% of people who self-harm report some other form of trauma history. This may include a childhood sexual abuse. Most of those traumas are going to be relationship, domestic, or sexually related. As you all understand, dealing with that kind of a trauma is so difficult, especially depending on the age that it occurs. People come up with lots of coping skills that are not the most adaptive for them. I see a question popped up. Nicole, when you say, does this include situations of bullying, can you explain that a little further? So from the last slide, if you're talking about the trauma piece, I don't think they were specifically asking about bullying as the specific form of trauma that the person experienced. However, anecdotally, what I have seen is that situations of bullying have definitely increased urges, especially among my LGBTQ clients. And that is a common topic that we'll see discussed among therapists who work with that population, is that we do seem to be seeing an increase in self-harm related to situations of bullying. But there has not really been a study specifically related to that. Okay, I think I got my slides a little bit out of order here, so let me just take a peek real quick. I have lost a slide, it seems like. Here it is. I skipped it somehow. So a common question that folks will ask is, why do people do this to themselves? Especially folks who are very pain averse. The idea of hurting yourself on purpose, just, it doesn't compute. It doesn't make a lot of sense. And so there are three primary reasons that people will tell you that they're self-harming. There are other reasons beyond this, but these are the three primary reasons that you will hear the most if you talk about someone. So especially with teenagers, you will hear that the feelings that they're experiencing feel too overwhelming. They just have too many emotions. They're all over the place. They're messy, those kinds of things. And so this person will cut, and the endorphins that come up from the pain, natural endorphins are created from pain. And so that person will get this feeling of release or relief from the cutting because these endorphins come up. After the endorphins come up, some natural analgesics will also kick in, and they'll start to numb out the actual pain. And so what this person is experiencing then is kind of this euphoric, finally, it's over feeling. A lot of times you'll see this reason and the third reason combined together of the feelings being so big and so confusing that by cutting, they've now focused their attention to something they know how to fix. So I have these big, overwhelming feelings. Oh my gosh, what am I going to do? I self-harm. I get this rush of endorphins that give me this release. The natural analgesics kick in. I don't necessarily feel this pain, but now I have this wound and I know what to do about that. People around me know what to do about that. They don't necessarily know what to do with all of these big emotions that I'm feeling. The other reason that you'll see folks report self-harming is because they're not feeling enough. So this idea of already being numbed out or dissociative. And by creating pain for themselves, they're able to then bring focus. It's a grounding skill. And for some people, they even do it because they feel like they need to cry, but they can't get themselves to cry. And so you'll see that described often of, I don't have any feeling and I should have some feeling about this and I'm not. And so they bring some pain into it, or everything feels so cloudy and foggy, but when I cut, I focus, I come back into myself. If you think about self-harm as a coping strategy, it makes a little bit more sense. If you think of the idea of, okay, this person has these things going on, they're trying to deal with them and they don't know how. And this is something that maybe a friend has done in the case of teenagers and college students, or they noticed somehow in their history that when things actually physically hurt, they started to feel better. It gave them something to focus on. Then they've developed this coping skill to deal with these overwhelming emotions. So when someone's calling you and asking for help, or sitting in front of you and asking for help, what do they need? How are you going to help them? The biggest thing is simply by listening to them. Venting is actually a really effective coping strategy, especially for the people who see their self-harm as a release or a relief. Venting is going to be great for them. And so having someone that they can talk to get those emotions out is going to be one of the best things that they can do. Also, for people who feel like they should be feeling but aren't, this is a great way for them to talk about how they feel like they should feel something, and maybe start to put words and clear away enough of the gunk that they can then talk about what that feeling is that's probably in there. It's just being hidden for whatever reason. Then, of course, with the folks who have those feelings that are so overwhelming and emotional, venting is a great way to get that out. Venting can be done through talking, so it can be done face-to-face with someone. It can be done over the phone. It can be done through text. It can also be done through journaling. And so talking with these clients about the idea of creating a vent journal for themselves to be able to talk through those kinds of issues on their own when they can't necessarily reach out to someone to be there in person for them. So the other way to help that I want to talk about is grounding. We did do some grounding when we were doing the breathing exercise at the beginning. That's a great way to help your client kind of come into themselves. Another strategy, and this is especially good again for people who are cutting in a heightened state of emotion as opposed to a reduced state of emotion, or the people who are dissociative. So the other way to ground is what I call the Take 5 strategy. You're gonna look around your space for 5 things that you can see, 4 things that you can hear, 3 things you can touch, 2 things you can smell, and if you can find it, 1 thing that you can taste. I will often have my clients at home create kind of a grounding center for themselves or a safe space for themselves. And when they do that, I will encourage them to put some strong flavored mints or candies in that area, because that taste can really snap people out of that kind of heightened or dissociative state. Will also talk to them about the idea of keeping a candle or some essential oils in that space. If they're burning, I do not talk to them about keeping a candle in that space, unless it's just a battery operated one that has some scent to it. You have to have something to burn in order to light a candle. It's not a good idea for folks who are burning as their form of self-harm. The other thing that you can have them do is, if it's safe for them to do it, to step outside. That can also give them a little bit more input, as far as things to hear and see and those types of things. And just that change in environment from possibly where they are self-harming typically to a different space can be really helpful. The other thing that I will always have my self-harm clients do is to create a list of coping skills. The idea behind this list is that they're going to use this list and they're going to try to do each thing for at least 30 minutes. I have them put 4 things from their own ideas on that list. And then the 5th thing is to call me as their therapist, not necessarily to speak with me, but to tell me that they are planning to cut and why. Now, for a crisis center, what you may want to change that to is that they call the crisis line to speak with someone. My piece is a little bit different with them because I am their therapist. What I will often have them do is think of a sitcom that they really like. And as long as it's never been included in their self-harm ritual before, then I will have them watch an episode of their favorite sitcom, listen to an album that they really like, pet their pets, go for a walk, call a friend, whatever it is this person is able to think of that feels good to them when they do. The idea being that the longer we can delay the behavior, the more likely it is that they're able to not do the behavior. So this idea of response prevention, keeping them from doing the thing, whatever that thing is. And then if they are going to do it, thinking about why and what they're trying to accomplish in doing that. And what that does is it moves their thinking from this kind of reactive emotional place in their brain to their frontal lobe, where they actually have to think through, why am I doing this? What's the reason behind this? What am I going to get out of it? What are my needs? Is this going to meet my needs? And those are all things that I'm going to have spoken with them in therapy about. From a crisis perspective, when you're talking to someone in that more of a crisis situation, you're probably going to be calming them. You're going to be a part of that kind of final step of, let me vent about some of these things. Let me try some grounding things, right? So you're going to be pushing them more into that direction. Whereas as a therapist, my goals are going to be slightly different than yours. So when do these folks need more than a crisis line? When do they need more regular support? When do you maybe want to look to refer to a licensed therapist of some sort? Or even to have a safety or welfare check done for this person, or to recommend that they go into even a higher level of care. So the first thing you're going to be looking at for this is the frequency. There's not really a lot of research on this, but honestly, if someone's calling the crisis line more than once a week talking about self-harm, that's someone who's going to need more intensive support than what a crisis line can provide. Now, what they may be doing is using the crisis line as part of their coping skills, and that might be something that you need to speak with them about, or if possible, if they're not an anonymous caller, if there's someone who's more involved in your program, to be able to speak with someone who's on their treatment team about appropriate ways of using your crisis line or your available support network. So kind of having an understanding for yourself and for your treatment center of what is appropriate and what does work for your center specifically, and even setting some policies about that. Intensity is going to be another thing that you'll want to look at. So if they're calling you and these self-harm sessions are lasting a really long time, or they're causing a lot of damage, and I know that's not a very specific thing, but if they're telling you that they're, filling in a 5-inch spot on their thigh, clearly that's too much. If they're telling you that they're cutting in a particular area that you know to be very close to a vein, and that they're telling you that they're cutting very deeply, that's another thing that's very dangerous for them. That's the intensity level where you may start to be concerned that their actions are more of a suicide attempt. And you will have to use some judgment there as far as, do I need to take this a step further to have a welfare check done, or to meet them at a hospital, or to walk them through whatever the next steps are as far as getting them more immediate care goes. And the other thing is your own lack of comfort. So any concerns that you're having for yourself, your own worries about this person in particular, right? Like, you've sat through this training, hopefully you've done more, because this is just an introduction. It's not going to cover everything that you need to know in regards to working with someone around self-harm issues. But that you're sitting with this person in whatever capacity that is, and you have concerns. And it's either because of what this person is saying, or because of things that you feel like you yourself don't know. And so you need outside opinions, outside advice on what to do next, or even just a gut feeling of, I'm sitting with this person and they just feel unsafe. I don't trust when they're telling me that they're not wanting to kill themselves. I don't trust when they're telling me that they don't want to die. Those types of things. And your gut is just saying, warning, sending those danger signs. Then that's a time when you want to look at what your next steps are. And again, a lot of times that may be dependent on the capacity that you're seeing this person in. It may be dependent on the system that your center has in place, the things that you can offer to folks. I know some larger centers have the ability to offer some individual therapy because they have licensed therapists on staff, whereas others don't have that capability and need to refer out. Those are things, especially if you're in more of a director position, or on a board, of looking into for your center of what are our next steps when we're looking to refer and get this person more support than really what they can get from, let's say, the crisis line, or one of our support groups, or even one of your individual therapists, depending on what their specialty areas are and whether or not you've set that up to be a long-term service or a short-term service. So those are all things to kind of consider when you're looking at options for referrals. So a big thing that I want you to think about in all of this, because these things, especially in working with trauma and self-harm, are really difficult And so I really want you to think hard about, how will you take care of yourself? What are the steps that you're going to take as kind of a daily baseline self-care for you, but also as I've just had someone call me and had to sit with them through this long conversation because they were in crisis and they were self-harming or they were getting ready to self-harm. That's going to create an intense reaction from you. And so having things where you yourself have created a safe space for yourself, where you yourself are taking on a daily meditation schedule, using yoga, using kickboxing, using jogging, using cooking, using whatever it is for yourself to keep your baseline, but then also having those extra components that you can put into place when something has been really intense for you. So those are kinds of the things for you to really think about. Another thing is, like I said, this is really a very basic introduction to things, and I'm assuming that there will be quite a few questions, which is why the presentation was a little bit shorter. But I wanted to make some recommendations for y'all around some things that you could read that might help you with your understanding of people who self-harm. One of the best books that I have read about what it's like for someone who self-harms is a book called A Bright Red Screen. Looks like this, as you can probably tell from the cover. It was written in the 90s. It's a very 90s cover. They use a lot of first person stories in here. So they have a lot of people telling their story of what's happened and how they got to a place of self-harm. If you have a history of trauma yourself, or if you have a history of self-harm yourself, you may not want to read this book, as it could be a very difficult one to read. Thank you. Deanna just put up a link to the book from Amazon. The other book that I think is great for folks who are working with trauma at all is Judith Herman's Trauma and Recovery. This is kind of a go-to. Pretty much every grad school program in counseling is going to use this book at some point in their training. But it's not necessarily written at that kind of like over everybody's head level. Even the grad students who are having to read it, it's really a usable book. And it really is great for folks who are able to be in that world and know what trauma is like. It gives great information about some of the neuroscience of trauma also, which I did not get into in this because that is not my specialty. But if you understand some of that neuroscience, you can also understand a little bit better how cutting can physiologically become a thing that people do. And if anybody has a specific question about that or wants me to talk about that more, I am happy to. It just gets a little complicated. So, any questions? I have my schedule blocked until 4:30, so we've got a good 40 minutes if folks have questions about things. Like I said, I did that purposefully with the understanding that this is a difficult topic. I also understand it's one that a lot of folks requested. And I'm assuming that if you're here, you had questions that I probably did not answer. So I wasn't sure what everybody's level of understanding of the topic was. So I am happy to sit here and answer questions. For those of you who don't have questions and are ready to bounce out, if you need my contact information, it's here. Otherwise, I will open the floor for any questions for folks. Summer, I was just thinking about your question some more, and not even just from a mandated reports perspective, but from a perspective of, do you talk to the parents about it? And with self-harm, that is something that I do bring parents in on, unless there's a reason not to do that, parents or guardians. So if the trauma is coming from a parent, I would not do that. I might talk to the parent who is not perpetrating the trauma. Clearly, there are going to be other things involved in that. There may be more of a legal guardianship situation going on. So there's going to be some differences there. But in most cases, if my teen is coming to me telling me that they're self-harming, then I'm bringing the parent or guardian into the room. So Allison has a question of, do you have any experience with self-harm in the military community? And if so, could you speak to any considerations or things to be mindful of? I personally don't have a lot of experience with that in the military community. However, I did work with veterans for quite a while, doing disability evaluations. And I don't know if there is some piece in their code of conduct about self-harm behavior that would lead them to this, but none of the vets that I worked with, I take that back. One of the vets that I worked with self-harmed, but he was the only one in that community who reported it. I am sure it happens, but I'm not sure as to why they're not reporting it. So I'm sorry I don't have more on that. I would be curious if there's a code of conduct issue. Quinn says, do you have any guidance on supporting folks who are self-harming, maybe not out of a dissociative state, but more of habit or possibly some OCD tendencies? Yes, so for those folks, the coping skill that works the best for them was that last one of creating the coping skills list. Typically what will happen is that they have this idea that they have to punish themselves or bad things will happen. And so kind of challenging that idea in and of themselves, but also that coping strategy list is going to be one of their kind of go-to things. Also working with them to change their habits. So if their thing is, well, I eat dinner and then I go up to my room and sit by myself and then I cut. Okay, well, then maybe let's eat dinner and not go to your room by yourself. Those types of things. That person is also probably going to need more intensive therapy. And so depending on what your center is able to offer, they may be someone who gets referred out pretty quickly. I'll also, Gabriella, like I did last time, send you a copy of the slides if anybody wants them or if you just want to send them out. I think that's what you did last time.
Yeah, of course. So after this webinar, probably later tonight, I will be posting this webinar up on YouTube, and I will send everyone who attended a link along with the slides.
Perfect.
All right, we'll go ahead and give another couple minutes for anybody that may be typing out questions, and then we'll go ahead and wrap up this webinar.
Sounds good. Oh, darn good. I'm glad that was helpful for you. I just said she's a case manager, and the suggestion about changing habits was helpful. For you, Donna, too, one of the things that might be useful if y'all are able to do it, especially if you're noticing that they're self-harming out of heightened emotion, is to have a ice smashing party. Basically, just take a big bowl of ice outside and let them throw the ice at the concrete and the cement, and that can release a lot of emotions. I've had clients also who go out in the woods and throw eggs at trees. As difficult as it's been to find eggs right now, that might not be the best option, but it's something about the full shatter of the egg was much more satisfying to them than the ice. And there may be other ways that you can simulate that.
All right, I think we'll go ahead and wrap it up. Dr. Benton, thank you so much for your time. For anyone who attended this webinar, at the beginning of, actually, no, we're still in June, never mind. So next week, we will be sending out webinar certificates for you attending this webinar. So please be on the lookout for an email from training@ncasa.org. And you will have a week to register to receive a certificate for attending this webinar. Dr. Benton, thank you so much for being here. Deanna, thank you so much for helping with the chat box and Q&A. We hope that everybody has a great day, and we hope to see you at more of our future webinars. Thank you. Bye.
Thanks.